USMLE-style question on increased ICP and papilledema. A 28-year-old woman presents to the clinic with headaches, transient episodes of vision loss, and pulsatile tinnitus for the past month. She has also noticed worsening vision in both eyes. She is obese and has a BMI of 34 kilograms per meter square. Neurologic examination is unremarkable except for bilateral papilledema on fundoscopic examination. MRI of the brain is normal, but MR venography shows stenosis of the dural venous sinuses. Which of the following is the most likely diagnosis? A. Pseudotumor cerebri, idiopathic intracranial hypertension, B. Cavernous sinus thrombosis, C. Optic neuritis, D. Central retinal vein occlusion, E. Giant cell arteritis. Answer A. Pseudotumor cerebri, idiopathic intracranial hypertension, IIH. Explanation: this patient has increased intracranial pressure, ICP, evidenced by headaches, transient vision loss, pulsatile tinnitus, and papilledema. The MR venography finding of dural venous sinus stenosis is commonly associated with idiopathic intracranial hypertension, also known as pseudotumor cerebri. Key features of EIH, most common in young, obese women. Symptoms: headaches, transient visual obscurations, pulsatile tinnitus. Fundoscopy: bilateral papilledema. LP shows elevated opening pressure, 250 millimeters H2O, with normal CSF composition. MR-MRV: empty sella, flattened optic discs, venous sinus stenosis. Pathophysiology: impaired CSF absorption at the arachnoid granulations, leading to increased ICP, optic nerve axoplasmic flow obstruction, papilledema, visual disturbances. Treatment: weight loss, acetazolamide, carbonic anhydrase inhibitor, shunting procedures, or optic nerve sheath fenestration for refractory cases. Why not the other options? B. Cavernous sinus thrombosis. Presents with ocular motor nerve palsies, CN3, ICE, proptosis, and chemosis, which are absent here. C. Optic neuritis, associated with multiple sclerosis, presents with painful monocular vision loss, not increased ICP. Central retinal vein occlusion causes sudden painless vision loss with a blood and thunder retina on fundoscopy. E. Giant cell arteritis, more common in elderly patients, associated with jaw claudication, scalp tenderness, and elevated ESR, not papilledema. Take-home point: idiopathic intracranial hypertension, IH, should be suspected in a young, obese woman with headaches, transient vision loss, and papilledema, especially if dural venous sinus stenosis is seen on MR venography. Would you like a question on